Okay, well, I'm going to go ahead and get started. So today I am talking about provider stigma and its relationship to drug-related maternal morbidity and mortality. Thanks first to study participants and then also to my students, Sonia, Victoria, Olivia, and Talia, who helped prepare this presentation. So although drug overdose is now a leading cause of pregnancy-associated deaths, research on drug-related outcomes during pregnancy and postpartum is limited. Both drug use and deaths have increased among women of childbearing age, and the number of women with an opioid use disorder at labor and delivery quadrupled in recent years. Overdose also peaks at about 7 to 12 months postpartum, making this a really critical period to think about how to improve services. But one of the major challenges is that pregnant and postpartum people who use drugs have far more limited access to and engagement in needed care. This really stems from structural barriers like punitive policies and stigma and discrimination, which is the focus of what we're going to be talking about mainly today. So stigma and discrimination towards people who use drugs is really pervasive in health and social service settings. Poor treatment or the expectation of stigma breeds fear and distrust, and that prevents people from seeking care, from disclosing substance use, and from engaging in drug treatment or maternal care. This is especially true for racialized and minoritized individuals. So for this poster, we pulled from existing literature and analyzed key informant interviews to understand stigma and discrimination for pregnant and postpartum people who use drugs. And 4 major themes emerged related to the pervasiveness of stigma, how stigma interferes with care engagement, the wider impact of stigma on families, and the intersection of drug-related stigma with racism. So not surprisingly, reported levels of stigma and discrimination experiences were substantial, and they led to shame, guilt, and also trauma for pregnant and postpartum people who use drugs. So using drugs during pregnancy is treated as, quote, one of the lowest of the low, and results in poor treatment or even service denial. We had an example of a visibly pregnant person being denied syringes at a needle syringe exchange. So this attitude really continues after childbirth, even when people make informed decisions about the health and well-being of their child. And as you see in this first quote, it says, "I think in pregnancy, the other piece is norms of motherhood collide with substance use." And this is, far-reaching. It's among people who use drugs, people in the harm reduction community, people who sell drugs, and then also providers. So if you're pregnant and using, it's seen as the lowest of the low. Because of this, stigma serves as a major deterrent to seeking care, disclosing substance use, and staying engaged in services. And the important takeaway here is that the experiences in health and social service settings were frequently traumatic for parents who use drugs. Providers are dismissive at best, but also inflict real harm that made engagement incredibly stressful. And there's also very real and well-founded fears about drug testing and having children taken away. So one of the examples was told to us is they gave the story of a mom who gave birth on the street, literally on the street, because her first delivery of her first child was in a hospital setting. And when she told them she was on methadone, it was so much more traumatic than literally giving birth on the street. And this participant said, and that to me, I think sort of says it all. This is where we really see some of the wider impacts of stigma and discrimination come into play. So it doesn't just create trauma for birthing people, but it ripples out to the entire family due to mandatory reporting and the carceral nature of our family regulation systems. So especially mandatory reporting makes doctors into cops, as this one participant said, which traps parents who use drugs and gives them fewer options for seeking and engaging in care safely. And the second example, this quote says, "What I've seen is women tend to go to the emergency department instead of the children's pediatrician because they still want their child to get care, but they're fearful of having a doctor do mandatory reporting and drug testing, which traps them." It's also really important to note that experiences of stigma and discrimination against pregnant and postpartum people who use drugs are not equally distributed due to systemic racism. So this results in differential access to care and legal protection for Black and Indigenous parents in particular, such that white parents are afforded far more leniency, receive more compassionate care, and are much less likely to be reported to ACS or child services. So in this first quote, it says there's a higher stigma on people of color. Even if they have access to care, they're less likely to have the system follow through with it. So say, she has the same parent advocate, she has the same lawyer, but the judge still refuses. If it's the exact same situation, what's right? And here the participant is sort of comparing the difference between, a Black mother and a white mother and what their treatment looks like. So collectively, this work really highlights how unjust policies and provider practices intersect to reproduce harms that underlie drug-related maternal morbidity and mortality. So considering structural barriers to care, especially stigma and discrimination, it's really necessary to support pregnant and postpartum people who use drugs by trying to mitigate the impacts of these harmful practices and to really counter these structural barriers. And I just want to end with a final quote from a participant that really sums up a lot of this. You can be a drug user and take excellent care of your child. Just using drugs doesn't necessarily mean you're bad. And I don't know if the world at large would see it that way. Thank you.
Great, thank you. It's a very nice presentation. Any question from our participant? Dr. West? Well, I have a question, Dr. West. Like, what are the factors that predispose pregnant women to use the medications? Are these patients, they already using the medications and they become pregnant and now they're finding is challenging or stigmatizing when they go their physicians, obstetricians to get help?
Yeah, so if a person, is using drugs and they get pregnant, there's a lot of very real fear about disclosing that to a doctor because, or other sort of health providers, because the likelihood of poor treatment is very high when you disclose that you're using drug use. And it's this sort of combination of drug use and motherhood that produces a lot of stigma. And instead of creating, supportive services for this really critical time that has an impact on both a parent and a child. And so a lot of, also we're learning is that a lot of medical professionals don't really know what to do with when people present who are pregnant and using drugs. Like, they don't know a lot about addiction medicine. They don't know about how safe it is to use medication for opioid use disorder, for instance, during pregnancy. And this results in really disparate treatment and poor treatment. And so it's often easier and feels safer for people to not disclose pregnancies, not disclose substance use, to avoid medical care because of these fears. And then also the big fear is fear of having your child taken away, which, is sort of, I think, the motivating factor for a lot of the people that we've talked to.
Sounds good. Thanks very much, Dr. West. Is there any other question? Or maybe at the end of these presentations, we can have a question and answer session if time permitting. If there is none, we can move over to second presenter, Dr. Michael Prini. Dr. Michael Prini is a program director, Howard University College of Medicine, CIDMAR, which stands for Center for Infectious Disease Management and Research. Dr. Prini.
Okay, is my screen sharing correctly?
Yes, yeah, we can see your screen, we can hear you.
Okay, excellent. So, good morning, everyone.
Good night.
This project started about 2018, and I came on to Howard. I started March 30th, 2020, and I came on thinking, well, I'll just be a program manager and I will not have any real significant challenges. And this is March 2020 and COVID started. So this project is a SPIN, so Special Projects of National Significance, HRSA-backed study, where 9 clinics across 3 jurisdictions, Florida, Louisiana, and Washington, D.C., were selected to study based upon the prevalence of incidences of gonorrhea, chlamydia, syphilis, and HIV. And what I found as an administrator, so I'm not a clinician, I'm an administrator, and I look at things from the perspective of the administrator and how to facilitate change, positive change on clinical activities, on administrative activities. This is kind of my perspective, along with Dr. Majoub's perspective. Dr. Majoub is the director, the medical director of Stigma. So this was backed at Rutgers. They were the program directors, the head, and they directed everything, set it up. And we started collecting data at SIDMAR in September of 2020. And we went through, had a lot of different screening results. We had, at Howard, we had 76 participants in the study, and we found prevalence of STIs in 11 of them. So that's a 14% clip. And then our jurisdiction, which we were the convener of, we had FMCS and Andromeda. Andromeda also had around a 14% clip. And then Family Medical was a little bit lower. They had 4%. But what that shows is there's a use for this type of study. And the study was set up so you'd have interventions, 4 of them specifically. So one was taking sexual health history. The second was patient self-collection with a NAT specimen. The third was provider training. So you're more or less teaching different providers, both internal and external to the department. And then the fourth was providing services that are welcoming. And I think the majority of these interventions make sense for most people, so I won't really go into depth. But the sexual health history, that was done with a CASI, audio computer assisted software, that more or less helps you privately answer sensitive personal questions. So if a patient is not comfortable talking to a provider, they're more apt to respond more truthfully. Eliminates data entry time and errors. It provides consistent questionnaire delivery, so all the questions are the same. You don't have one provider asking one set of questions and another provider asking another. So your data is succinct, and you're able to collect data and qualitative information and quantitative information in a more regulated manner. And it works well for patients with literacy issues. So we did have some patients who had some basic literacy issues, and we had patients who speak English as a second language. So this helped with that as well. And since we started during COVID, we had a number of challenges that, as an administrator, we had to overcome. So with COVID, we had the restrictions on people coming in. So we had limited in-person appointments and patient no-shows. That was more or less part of the process of us doing the study. And when we did the IRB for this study, we didn't have any allocations for the ability to do a CASI via phone or via do the sexual health history via phone or via Zoom or anything like that. So everything had to be in person, which obviously lowered the number of participants we could get for the first year or so, because we had so much telehealth by default. We had weather challenges. We had civil disturbances. I'm in the Guard. I was actually deployed for both COVID and civil disturbances. So these are significant things that impact the flow of a clinic and its processes. We had administrative obstacles, just dealing with more or less basic things like trying to spend money, invoice, do things like that. That prevented our efficacy from being maximized. Data upload was challenging at times. There were systemic IT issues at some of the locations, specifically the DC jurisdiction, because all of us were using different EMRs and different ways to upload data. Time, this was a significant one because you had to fit the ACASI into a busy schedule. So you have a patient comes into the office, they meet with, the secretary front desk, then they meet with an MA, then they meet with a provider, then they meet maybe with a pharmacist, then they meet with a caseworker. So there's all of these appointments within a regular clinical visit. And then you have this 10 to 15 minute survey that has to be fit in there somewhat. So as an administrator, you're thinking, okay, how can I still collect this data? And then how can I still get this going and fit it into the clinical visit without being too disruptive, without impacting the patient's experience in a negative manner. Staffing, some of the jurisdictions were short on staffing, there's turnover. And then patient reservations, a lot of them are actually related to stigma. So that's something that would come up. And stigma really goes on a lot of different floors for an administrator. There's from the patient level, this is the individuals who are interacting with the patients. The patients are not thinking that they would fall into specific categories of folks who would need self-testing, or they're like, oh, that's for a certain type of patient. That's not for me. So you have to overcome that, and that's done through education. You have personnel who are resistant to adopting change, such as adopting the ACASI for multiple reasons. I actually had one provider say, I don't want to do that. It more or less implying it was an age-related thing. So you have to gain buy-in from the providers, so overcoming them through types of education. And then there's perceptions. I'm white, and I'm working within a specific demography. If I'm telling them, hey, do you want to try this something new? It raises an eyebrow, and that's just a reality. It's a bias that has to be overcome by just more or less putting it out there. So a lot of the stuff is done through, again, gaining buy-in, and then education of staff and patients, and emphases on adaptability, overcoming objections, almost like sales. So we had a lot of sustainability, more or less, how can we continue on these gains that we had? ACASI works. It's a good way to catch. It's a good way to catch a lot of STIs. So these screening results would not have occurred if they weren't doing self-collection, if they were doing patient visit in a different way. So we want to continue what we're doing. You do reduce stigma through regular training and awareness. You retain current STI intervention measures. So we had very positive results when it came to just decorating the clinic with welcoming materials. And essentially the outcomes from the administrator standpoint, some of the STI screening was hindered for a bunch of different reasons, but the interventions, like I said, were helpful. And the bottom line, and this is kind of where I conclude, is work with and educate the younger populations, which were the folks that we were catching. We work in a university environment, so we have this opportunity to really catch a lot of folks who are in that 17 to 30 age range, and that's where we can make our biggest impact. And that requires a lot of education. We have these on the poster, I have statistics and everything, but it really just comes down to educating the individuals. And we can do that through outreach. We can do that through individual interventions. But ultimately, the way to make this type of programmatic change effective is through education of staff and patients. And my friendly disclaimer is at the bottom for HRSA. So that's my presentation. Barring questions, that concludes it for me.
Very nice. Thank you. I'll still say, Dr. Praney, for your presentation. You are the administrators. I have a question regarding, you mentioned about the education of the patients, of the community, as well as education of the healthcare providers. How we can promote the education, being a part of the SIDMAR as you are dealing with the patients, interacting with the patients, what is the best way of increasing the awareness in patients as well as in healthcare providers? Like what should be included in education?
Well, the basic way to train the providers is you have to schedule training, and it has to be built into your training schedule as an individual administrator. So we did trainings as part of this study, and then what we did is that we retrained the staff. So as participants, not everybody at SIDMAR was doing SPINS trial. So people who were on the SPINS trial, they had this training, this provider training, and then we brought that training back to the rest of the staff and then trained them for their awareness. That's the first way to train the staff. It's that continuous built-in training session. And then for the patients, it's really just about open communication and then providing them with that type of information the best way possible. You have to understand who your patients and clientele are. How are they communicating? If they're communicating via electronic means, more by social media, whatever, that's how you have to reach them. If they're more apt to communicate in person, they feel more comfortable with that, that's what you have to do. So it's really about knowing the people whom you're interacting with and then meeting them. You can't expect them to come to you. You have to go out and reach them.
Okay, sounds good. Is your studies also published, or are you planning to publish it so that?
Yes, I'm planning on doing a paper on the administrative aspects. My colleagues, Ms. Megan Presley, is going to be doing further studies and working more with the SPINS team. That's the 4th year of the study, is really the dissemination of the findings, and that involves presentations, obviously, like this, and Ms. Presley's, as well as publication afterwards. So this is the first step, and then we move forward with the academic professionalism that's to follow.
Sounds good. Sounds good. Thanks very much, Mr. Craney.
Thank you.
Any other questions from our participants, the panelists, Mr. Craney? If not, we can move on. The third presenter is Ms. Rian Cannelly. She is from Emory University. So please introduce yourself. And
hi, everyone. I'm Ryan Keeley. Can you see my screen?
Yeah, we can see your screen.
Okay, great. So we really wanted to understand how stigma, family empowerment, and mental health literacy interact to influence treatment seeking for children's mental health. And we want to start out with the problem. So what do we know about the prevalence and treatment of mental health conditions among children? We know that about 6% of our youth, ages 3 to 17, have depression, about 11% have anxiety. And of those youth, 22% with depression and 41% with a diagnosable anxiety disorder do not receive treatment. So there are clearly profound barriers to children receiving that adequate care. And that's important because untreated mental illness in childhood is associated with a lot of increased risks for what you see on the screen and more. And that really leads us to the inspiration for our study. So we looked at the gateway provider model to help us understand patterns of care seeking in children's mental health. And the gateway provider is really defined as that person who either recognizes a problem and facilitates that care, or instead transmits stigma and negative messages about formal mental health treatment, acting as a barrier to care. And so we looked at 2 types of stigma in this types by constructs model: affiliate stigma, which refers to the stigma that is felt or internalized by parents or guardians of a child who has a mental health condition, and label avoidance, which refers to parents' refusal to seek treatment for their child to avoid stigmatizing labels for themselves and for their youth. So how do we overcome these barriers? That's where mental health literacy and family empowerment really come into play. So mental health literacy, the knowledge, attitudes, and beliefs about mental health that facilitate the appropriate recognition, treatment, and prevention. And then family empowerment, which is conceptualized across 2 dimensions. So level of empowerment, which is in the family, in the community, in the service system. And then 2, the way that that empowerment is expressed. So behaviors, beliefs, attitudes. And importantly, mental health literacy has really been linked to label avoidance and family empowerment to affiliate stigma. And we'll get back into that when we go into our results and hypotheses. So that leads us to our present study. We recruited a national sample of 89 participants through MTurk. Participants had to have been diagnosed with a mental illness in childhood and be between the ages of 18 to 26, as that is the average age before first birth. We didn't want our participants to be parents themselves, as we thought that could interfere with the results of our data. And these are some of the measures that we included. A quick demographic breakdown: we had a primarily white and primarily female sample, so not as diverse as we were hoping for. And now our results. So our first hypothesis was that mental health literacy would moderate the relationship between label avoidance and care seeking. And that's exactly what we found. So to break this graph down for you guys a little bit better, we set the conditioning values of the moderator variable, in this case, mental health literacy, at -1 standard deviation below the mean, and 1 standard deviation above the mean, to represent low, average, and high levels respectively. And on that x-axis for label avoidance, the same applies. So -6 would be 1 standard deviation below, 6 above, and 0 the mean. What we found was that for parents with low levels of mental health literacy, label avoidance significantly and negatively predicted parents' willingness to seek care, whereas those average and high levels of mental health literacy, label avoidance did not significantly predict parents' willingness to seek care. So it acted as a sort of buffer in a sense. And this explained about 42% of the variance in our model. And then our second hypothesis was that family empowerment would moderate the relationship between affiliate stigma and care seeking. And again, that is what we found. So for family members with low or average levels of family empowerment, affiliate stigma significantly and negatively predicted parents' willingness to seek care. And again, that high family empowerment level, that acted as a sort of buffer, and affiliate stigma did not significantly predict those members' willingness to seek care. And this explained about 51% of the variance in our model. So importantly, the study was really the first to examine how parent or guardian stigma influences treatment seeking for children's mental health, examining mental health literacy and family empowerment as ways to overcome that barrier in this relationship in the context of the gateway provider model. And it really provides support for current programs that are proven to increase mental health literacy and family empowerment. We have several limitations. It is a cross-sectional correlational research design. Participants were asked to report retrospectively on their childhood experiences and their perceptions of their parents. So there could be some sort of uncertain congruency between parent-child reporting. But what we really want to emphasize is that these perceptions are very important for long-term outcomes as well. Not a racially diverse sample. Mental health literacy was an item. It was not a complete measure, and it is a complex construct. So given that one doesn't exist for parent perceptions, we think that's an important future direction. And then construct validity, our measures were modified to account for the fact that these were perceptions of parents, not direct participant perceptions. And then importantly, future directions, creating that criterion standard measure of mental health literacy, replicating these findings with a racially diverse sample would allow us to look at structural characteristics and how these patterns might change depending on demographics. And then longitudinal studies would allow us to test mediation models and examine how these variables might change over time. It suggests the need for improving mental health literacy and family support among those at-risk families with low levels of both variables. Government agencies could provide grant funding to cover the operation costs for mental health literacy and family empowerment programs, as these are typically run by volunteers. And then finally, training child and adolescent psychiatrists on best practices for handling the burden of stigma on parents. It's not usually incorporated into their training protocols, and it could cause a lot of differential outcomes for different families. And just a quick thank you to everyone, my mentor, the program that I was working with, NIDA, for funding the research that we did, Howard University for hosting us, and my statistics professor for providing a lot of statistical guidance on the project, and friends and family.
Appreciate it. Thanks very much, Dr. Kenley. Very nice presentation. One of the job of the moderator is to keep track of the time, and because of the time constraint, I'll move to the next. I'll hold my question, although there are a lot of questions that can be asked and discussed. We can discuss it more about the mental health, which is extremely important. But because of the time constraint, I will move on to our next participant. Next presenter is Dr. Miller. So Dr. Miller, she's presenting on the osteotomy patients experiencing stigmatizing, and Dr. Miller is from University of Illinois. Dr. Miller, the mic is yours.
Sorry, I'm having technical issues with sharing my screen. So can you hear me okay?
I can, yeah, we can hear you. And
okay. It's not letting me share my screen. I think it's a new, well,
so TJ, are you here? Are you, can you help Dr. Miller to?
Hi, good afternoon. I am the tech. Yes, she does have share rights.
Okay.
So if you look down in the center of your screen, it'll have a green share button.
Yeah, there's a I have like a, let me try this. It's like a red exclamation, like a error.
Yes,
problem.
exactly.
I think
Yeah,
it's
the
a
share.
new computer. I'm thinking it's a new computer problem, honestly. I mean, I see when I hit share, there's 3 different options: entire screen, window, and Chrome tab. And I clicked my PowerPoint, but it's not working. Yeah, I don't know. There's like a red exclamation mark on it, so it's kind of weird. I chose window, chose the actual PowerPoint. I'm sorry. I don't know. It's probably a computer problem, honestly. So I think it's a Google Chrome new computer problem. So
TJ is trying to help. Hopefully you will come up with some
I don't know if I can just
way
like,
to how to present your slides.
like give you
Unless you can email him to Dr. Khan, he may be able to share it for you.
Okay. Try that. What email address?
So my email address is my first name. Let me type in the text box.
Thank you. I'm so sorry. I don't know. I think it's a new computer problem, honestly. Which it works when I Zoom synchronous for my 400 student class, and it works fine then, but I don't use Google Chrome, so I'm thinking it's.
So I text my email in the chat box, and you can see it. So can we move, because of the time, can we move to next presentation and come back to Dr. Miller presentations? Because it might take a little time to share the slides. Is that okay, Dr. Miller? Okay, sounds good. So TJ, we are moving to our next presenter, Megan Ware. She's here. She's from Howard University, Stigma. So Ms. Megan Presley, can you hear it? Okay, maybe.
Sorry, I'm here. I'm here.
Okay.
I'm trying to share my screen at the moment.
Okay. Yeah, please go ahead. So Ms. Presley, she's from Peer Support Specialist, Howard University, Stigma Clinic.
Okay, can you see my screen?
Yeah, I can see you. We can see your screen.
Okay. Good morning, everyone. My name is Megan Ware Presley. I am the peer support specialist at Howard University Stigma Clinic. And today I will be presenting the intersectional stigma between HIV and STIs. I work very closely with Michael Perini, Dr. Michael Perini, and he did a really good job at going over a portion of the great work that we did together. But today in my presentation, I will be focusing, as I mentioned before, on the intersectionality between HIV and STIs, coming from a peer support specialist perspective, and from my perspective to help our patients. So the reason why we were chosen as a site to do this study was because the HIV rates in DC is very high. According to the 2020 HIV STD surveillance report, there's currently 12,408 DC residents living with HIV. And though public health experts are doing a great job at declining those rates, sexually transmitted infections are rising. And as it relates to the relationship between the intersectionality and public health, persons with HIV do have an increased risk of experiencing intersectional STI related stigma simply due to the unfair beliefs that our society has placed around sex. So one of our objectives, we had several objectives, and the main was to determine the normalization of bacterial STI screenings, testing, and treatment in patients with HIV to improve the intersectional stigma and STI care continuum. And as it relates to the relationship between these intersectionalities and public health, another objective was to acknowledge the existence of these intersecting identities at the macro level. So that's social stigma, self-stigma that affects our patients, and understand the complexities of health disparities for these oppressed groups. So our methods, as Dr. Perini went over, it was clinical and non-clinical interventions that address the intersectional stigma. So at a micro level, our clinic, they regularly check for STIs in our patients living with HIV. So that's the screenings that was done on the ACASI, which is an audio computer assisted program that's on a tablet. And we also implemented LGBTQ welcoming measures around the office. These micro level interventions, I believe, from, like I said, a peer support specialist perspective, intersected with stigma at the macro level. So these screenings, testings, treatments, and welcoming measures, I felt like gave insight to the individual experience that a lot of times affects patients' their attitudes and sexual behaviors. Some procedures were designated as stigma champion, which was our medical director, and she took the lead in making sure that our clinic staff was trained so that we could welcome the patients during their visit and reassure them that they're heard and accepted. That's something that we did learn